Hi, welcome to our Facebook Live chat on high-risk prostate cancer and the Poten-C clinical trial. I'm Kristen Holland-Shear here at UT Southwestern, and today we're joined by Dr. Raquibul Hannan and Dr. Desai. We are excited to have this chat. It's definitely an important conversation. You know, we are going to be going for about 30 minutes, so now's a great opportunity to start asking those questions in the comments section. I will remind you that as normal that, we can't answer very specific patient questions, but we can certainly talk in generalities, and we will take as many questions as we can get to. So, welcome. Thank you both for joining us.
Thank you for having us.
Absolutely. So, first question, what are the stages and different levels of prostate cancer? If you want to start, Dr. Hannan?
Sure, of course. So, the American Joint Committee gave the staging for prostate cancer, stage 1 to stage 4. As with other cancers, there's similarities. Stage 1 being low risk, but stage 4 being metastatic disease. But for prostate cancer, it's helpful to categorize it in risk stratifications or different risk groups. So we divided into low, intermediate, and high risk groups based on really two things essentially: PSA and the Gleason scores. So the PSAs, the cutoff in general is about 10 or less, puts you in the low risk category, 10 to 20 puts you in intermediate, and more than 20 puts you in the high risk category, but that is combined with Gleason score. But again, this is a simplification. There's a lot more things that goes into it. But the Gleason scores overall are now into Gleason grade groups that goes from 1 to 5.
Okay.
Again, 5 being the most aggressive cancer, and this is based on what the pathologists see as aggressive features on the cancer under the microscope after the biopsy. So that's overall with that, we divide them into low, intermediate, and high risk groups, and that's what really decides the treatment for the patients.
Okay, do you want to add anything, Dr. Desai?
I think that's about right. I think with a wide group of heterogeneous diseases and presentations, you're trying to make sense of where a patient's risk of disease lies in that spectrum. And as Dr. Hannan pointed out, localized versus metastatic, that's our first break point. And then these risk stratifications that are really meant to predict what is your chance of progression, not only to local extent of disease, but to different parts of the body. And that will guide then our treatment intensities and whether our focus should be on intensification for cure or on de-intensification potentially for surveillance or even quality of life improvement by reducing the intensity of treatment.
Okay, so you both mentioned kind of this Gleason score and grade groups. What do you mean when you say those? Could you explain a little bit?
Sure. So the Gleason score, and this is something you will see on the pathology report all the time. You'll see numbers like 3+4, 4+3, and so on and so forth. So when a pathologist looks at the tumor cells under the microscope, they really rate it from 1 to 5, 1 being least aggressive and 5 being most aggressive. And then they look at the preponderance of how much grade 1 is present, Gleason grade 1 is present versus grade 2. And the number that as what is the most predominant as first, and plus the second predominant. So 3 plus 4 is 3 more predominant, and then 4 the next predominant. So overall, from 6 and below, you have low risk. 7 is intermediate risk in the Gleason grading. 8, 9, and 10 would be high risk. And then the Gleason grade grouping was introduced a few years ago just to simplify all of that into a 1 to 5 system.
Okay.
1 is really 3+3. Whereas 5 is Gleason 4+5 or 5+4, which are the very aggressive cancer. So that's the grading system. All of it is really based on the histology on how the cancer is looking under the microscope.
Okay. So I'm assuming that depending on where you fall on that scale, that will determine your treatment options, correct?
It's one of the main features as a predictor of the biologic aggressiveness of the cancer. Absolutely. Amongst the other features that are not pointed out, such as PSA, the T stage, which we touched upon briefly only because it's become more complex in the era of MRIs, which are added to our information on the extent of disease, whether it's in the prostate or beyond. That's a critical feature, as well as just the overall staging of disease spread throughout the body or lack thereof.
Okay, so let's talk about treatment options. I know there are definitely some new ones. There are some that we've worked on here at UT Southwestern. What are the options that people have when they've received a prostate cancer diagnosis?
So that's a fairly complex and a loaded question, and again will be very different individually based on the patient characteristics. But overall, you're really talking about 4 types of treatments, and let's go over that. So you're talking about active surveillance for those patients that are very low risk or are favorable prognosis. Then you have surgery or radiation as treatment options, and then you have hormone therapy as treatment options. And for the most part, you're talking about a combination of these that would be appropriate for the patient. So then we would have to go back to the low, intermediate, and high risk patients and look at the characteristics and decide which therapy or which combination of therapy is the most appropriate for that patient.
Okay. Do you want to add anything, Dr. Desai?
No, it's a very complex discussion, and I think it, just as Dr. Hannan very well lays out for both our residents as well as the patients, it comes down to just making divisions. Are we talking about curative treatment, palliative treatment? Are we talking about treatment or all, or surveillance? Are you talking about intensive treatment or less intensive treatment? And you got to find yourself in there before you start making specific recommendations, which get more technical when you add in not just a tumor risk to the patient's life, but also their baseline, primarily urinary function issues and other medical problems that can guide our choice of treatment.
Okay. So we are getting some questions in, and so I want to kind of step back and take a couple of these. We have one here from Corey, and the question is, and let's start with you, Dr. Desai. What advice do you have for patients diagnosed with prostate cancer, particularly younger men?
Yeah, so for younger men with prostate cancer, the question still remains the same as with older men, depending on what age we're talking about. But the first question that has to come to mind is, what is the risk of this disease, and is there compelling evidence that we need to do anything about it? I think in recent decades, it's become more and more the clear truth that prostate cancer is a disease to a certain extent of aging, and we need to differentiate those men who have high propensity towards progression or death from amongst the vast larger legions who will have more indolent disease. And so for younger men, it still remains the same of finding out what is your risk of disease based on PSA, Gleason grade, T staging, your family history of prostate cancer. All these can affect your risk. It's all the same in that regard. Then in terms of actually deciding on treatments, if you do need therapy, the questions then go more to that are more unique to younger men will be, well, younger men tend to have more sexual potency issues to worry about than older men. That must factor into decision making regarding treatments. They also have longer time to survive. Many times, if you're very young, beyond what many of our studies have a good follow-up on. So maybe your decisions may differ in terms of intensity of treatments if you are not quite sure that the available studies address your duration of life. For instance, if you had a study that addressed mainly 70-year-olds and you're 40 years old at diagnosis, maybe we might err towards more aggressive therapy for you, simply because you are worried about what may happen after the follow-up of that study was basically over. And so those are the main considerations. The peculiar side effect profiles you worry about that earlier phase in your life, the risk that disease poses to you and the family issues at hand, because you also, if you've been diagnosed earlier, have a high propensity towards genetic predisposition, and the same issues that affect other men, which is, do I need treatment in the first place?
And just to add a little bit is that for somebody who is young, we tend to recommend the treatment over the active surveillance in general, because that person just has so many years ahead of them, and that gives that prostate cancer the chance of recurrence in the long term. So we tend to recommend more treatment than active surveillance. And if you are going to do active surveillance, definitely do very careful analysis, and there is multiple DNA testing and genetic testing analysis available to make sure the Gleason group and the PSA, what is predicting the aggressiveness of the cancer, is indeed the same in the genetic makeup of the cancer. And then carefully consider surveillance, and the goal of the surveillance there would really be to postpone treatment safely. So you're really not getting away from the treatment necessarily. You will need that. It's just a matter of safely postponing the treatment, and that should be the focus. But otherwise, we would recommend the treatment, and then you have to decide between surgery, radiation, or a combination of hormone therapy based on the risk groups and the details of the cancer.
Okay, really good question, Corey. We have another one here. This one is from Andy. Her question is, how often should someone be screened for prostate cancer?
Highly controversial area. Even our experts are disagreeing on this. This is going to be unsatisfying answer because we don't have clear data on personalizing screening to each person. And it's clear the population and level of statistics that sound good across 1 million patients applied to each individual man can be very different how you perceive the benefits or risks of that. So the simple answer is screening should occur after a conversation with your urologist, your primary care provider, regarding your personal risks, your personal preferences regarding tolerating risk of cancer even occurring. If, for instance, you are 40 years old, you had multiple members of your family diagnosed with prostate cancer, especially lethal prostate cancer early ages, well, no one's going to argue with early PSA screening in your case. If you're 70 years old and someone wants to add on a PSA to your testing without any history of prostate cancer, that requires a discussion because you may find something you don't want to find. That was the discussion that led, in a lot of parts, to a very guarded rollback of PSA screening some years ago through a national task force called the USPTF, which was very controversial, which arguably has resulted in less PSA screening, which then led to higher propensity towards locally advanced presentations of prostate cancer that are occurring now. Whether it's a good or bad thing by avoiding over-treatment, yet having more underdiagnosed patients, is an ongoing debate. So there's a personal question. Secondly, the assessment of risk of those PSAs has also changed. It's become clear in the last few years that a rising PSA alone should not alone trigger a biopsy. We now have genetic tests, PSA, blood-based tests, free PSAs, 4K scores, other kinds of commercialized tests, and now even MRIs prior to doing a biopsy, which can increase your yield for clinically significant prostate cancer diagnosis. Meaning, you don't want to find at a younger age, and you need to, the cancer you need to act upon. It's not always great to find Gleason 6 in a young man who will now have to deal with the consequences of the anxiety of potentially surveillance or making treatment decisions on a disease that arguably would not have been diagnosed until later in life, when you could have equally efficaciously acted upon them without all those intervening years of anxiety and side effects. So I think the changes occurred saying screening is reasonable, especially if you're risking your family, but it's not just primary screening, screening-based decision-making with genomic tests and even MRIs prior to even getting a biopsy are very absolutely critical in recent years, which have improved to make it more easy that decision and less consequences sitting there with the PS that's risen now we know what to do.
Okay, all right.
That's excellent summary, and as Dr. Desai mentioned, it's a very controversial topic. Just wanted to point out that it's not just the age, but also the comorbidity. I mean, all the other factors Dr. Desai mentioned, but if there is a 70-year-old with heart disease, diabetes, and other things, then you have to look at what benefit you will get even if you have prostate cancer and treat that, whereas it is really, that's not going to decide your longevity and other things. So this is a discussion you want to have with your primary care physician based on multiple factors that you have.
Okay, all right, so we've got a couple more questions that came in. This one's from Kathy, and her question is, if someone is diagnosed with prostate cancer, should they seek out a second opinion on treatment? Start with that one.
I'll take that. So, as with any diagnosis, we always encourage second opinions because it gives you different perspectives. And what is most important is to get a second opinion from someone from a different modality. So if you have seen a urologist, definitely plan to see a radiation oncologist. If you have seen a radiation oncologist, plan on seeing a medical oncologist, because each physician will bring with you a different perspective and different set of recommendations. Oftentimes it's also not just recommendation, it's how they are presented and what side effects. So at the end of the day, between your main treatment options of radiation, hormone therapy or surgery, what you want to look at is what are their side effects and what are their chance of side effects. And the cure rates for the most part are very equal, but it's really the side effect that's going to make you decide what you're more comfortable with and what percentage of chance that you will get. So it's really very important to get second opinions.
Okay, we've got a follow-up question to that, and her question at the follow-up is, what's the difference between surgical and radiologic treatment?
That's
a great question. I think for localized prostate cancer, this is the key question for those needing treatment. Those are the two standard of care modalities for treatment of localized prostate cancer. Raging debates have occurred over years. We're all biased, and it's important for us all to say that when you walk into a room, I'm a radiation oncologist, I'm biased towards radiation, however X, Y, and Z in your case. We like to think we're fair, but we can't possibly be fair when we're ourselves fearful of side effects in a very personal way. You or I have different perceptions, even amongst us, about what we regret in our patients' therapies. So I think to return to your question regarding surgery versus radiation, what's different about them? Well, surgery involves very basically the removal of the prostate with plus or minus a lymph node sampling or even dissection based on the risk of disease in order to remove as much as possible the prostate cancer while retaining urinary function. What are the critical side effects of prostatectomy or removal of the prostate? Well, there's operative recovery. Nowadays, robotic surgeries, laparoscopic surgeries that are limiting the amount of blood loss and hospital stays, but nonetheless, you are left with oftentimes a catheter, maybe a hospital stay of a short duration, recovery from the surgical incisions, as small as they might be, still require some time off from work and usually some restrictions in weightlifting and that sort. The main profile side effect that men talk about though after the surgery is really the incontinence or urinary leakage due to lack of control, and then the sexual impotence. Even with nerve-sparing surgeries, many men and us, we were all discouraged to find that it's not a guarantee of maintaining sexual function, and there's a rehabilitation. Like any other surgery, you go through hip surgery, you know you're in for physical therapy. Just like that, a good physical therapist can make a surgeon look great. And our team, I know we're really proud of them because they work tightly with physical therapists to rehabilitate the pelvic floor to regain urinary continence and even sexual function over time. You just have to be patient with it. And that's the surgical flavor. Right. Radiation involves not incision, not going in, but there's even multiple radiation techniques. There's internal radiation with radioactive seed implants called brachytherapy. Put in the operating room, we put radioactive seeds in the prostate, not by cutting you open, but through needles, okay? Then there's external radiation, which has an amalgam of short, intermediate, and long course radiation adapted to your urinary function risk scores, in which you sit on a table, lie down in a very careful position, and have radiation delivered to you by a machine from the outside in. The side effect profiles of this will primarily be loose stools potentially, though now we have rectal spacer gels that diminish that risk, fatigue, urinary frequency, urgency, generalized urinary bother is the main risk of radiation, whereas the leakage of surgery. And I know I'm going to be ad-libbing here, but a lot of times you're left with multiple good options you can't go wrong between. And if anyone usually says, oh, this is the right one, everything's wrong, be careful of that because, again, we have our biases. So get the second opinion, hear them out, hear what you are going to be able to adapt to in your change in your life that's going to come. There's different changes. Good quality life studies have shown that people, years from treatment, whether they have treatment A or B, usually have the same level of regret one way or another, tied to primarily not knowing about the other options. And so it generally tells me that people interpret changes in their life in equal ways as long as you're able to anticipate them coming.
Okay. Just to add a few things to it. So, I mean, for the longest time, because surgery and radiation are so different modality, we didn't have a randomized trials. But finally, we had a large randomized trial done in Europe where they randomly placed patients into radiation and surgery group. It's called the Protect trial. Came out in New England Journal of Medicine 2 years ago, and you can look that up. What it showed mainly is that radiation and surgery have really equal outcomes. So in terms of efficacy, we know that they're equal. Again, the difference really is in their side effects. And it's really very minor patients where you would say that, okay, one is not an option for you than the other. But it's more in terms of preference and more in terms of side effects. So to give you an example, if a patient has a lot of urinary symptoms, obstructive symptoms, then that's the only time we would say that, okay, maybe if the surgeons go in and take out the tumor, then you will have easier urination, and that may be a balance you want to take over possible incontinence that you may have from the surgery. Whereas, that's really very, very minor times when we have preference one over the other. But other times, it's really you're balancing the side effects of radiation versus the surgery.
And it's even more complex. So there's other layers. There's what if you get hormones to radiation? How much hormones? Well, you need radiation after surgery.
Right.
There's a lot of layers that have to be personalized to your case, and if you get a stock language of this are your options, it's usually you can do better than that. And so yes, it's good to learn about general radiation modalities and surgery. These are the big differences, but you got to personalize it. Is what I think what you're really saying.
Yeah. Okay.
And these are good questions.
Yeah, good question. So we've got one now. One of the things we wanted to talk about in this chat particularly was several clinical trials that are underway here at UT Southwestern. One of them being the Poten-C trial, and we've gotten a question about that. And it's from Kevin, and it is, what is the key difference of this clinical trial that is preserving potency better than other past radiation therapies? So how does the Poten-C trial differ?
So let me start with that, giving a little bit of background of stereotactic radiation, and then I'll hand over to Dr. Desai to talk about the Poten-C trial itself. So the stereotactic radiation is high dose focused and ablative radiation, where we try to compress the 44 treatment daily 9-week course of radiation into just 5 treatments. That are one, very convenient for patient, but convenience is really not our goal. our goal is to make it more potent in killing the cancer cells. And prostate cancer research and radiobiology also predicts that it responds to more dose when it's given in each fraction. The problem, of course, with that, as soon as you're trying to give more dose, you also have potential for more toxicity. So we are actually here as an institution, one of the first to apply and devise the technology to apply stereotactic radiation for prostate cancer patients, led by Dr. Timmerman, and we started our first clinical trial back in 2007. So we were able to deliver 5 treatment radiation, stereotactic radiation in phase 1, phase 2 trial. We enrolled 91 patients, relatively smaller trial, but as with all prostate cancer trials, it takes time for the data to mature, and we had just reported our 5-year outcomes about 2 years ago, where we showed a 98% PSA cure rate. So biochemical cure rate at 5 years was 98%, which seemingly is higher than what you would see with conventional radiation and surgery. However, of course, it is one trial, and we need to verify that with multiple other trials. We saw a little bit of higher rates of rectal side effects in that trial, and that's what we mitigated in the next trial, which we just completed, and we're about to ready to get to publishing it, with the spacer gel protecting the rectum. And now with that, we are seeing the rectal side effects rate same or lower even than what we would see with the conventional radiation. So now that we have really optimized the outcome, it's really our focus to minimize the side effects. And one of the main side effects is the sexual erectile dysfunction that happens in about 40 to 50% of the patients with radiation, and that's where we are devising and applying, doing the Poten-C trial. And over to Dr. Desai to talk about the trial.
I think that's an extremely good analysis of where we're going. I applaud Dr. Hannan, who's part of that trial, as well as Dr. Timmerman. It's easy for me to kind of take the reins here on this trial, but the reality is you can't think about making people's lives better after treatment if you can't cure them in the first place. With that said, I think the group was very right. When you get 1% death rates at 10 years from localized prostate cancer of low intermediate risk, in the PROTECT trial for United Kingdom reference, when you have 95+% PSA cure rates across various modalities with lower intermediate risk, you shouldn't pat yourself on the back. Your reaction should be, that's too high, that means we're over-treating some people, and what are the consequences of this treatment? So they checked off the rectal side effects first, the rectal spacer gel through Dr. Folker's trial with you, and now we're attacking the most pronounced, common side effect of treatment, whether it be radiation or surgery. We always bicker about this nurse-sparing surgery or not, or radiation's better, that's not good. But overall, the main impact of treatment on prostate cancer is about a 50% reduction in sexual potency amongst initially potent men at around 1 to 2 years out from treatment, and that's pretty hard to fix. There are various treatments for that, but it's a major impact and insult to men that we just don't talk enough about, because it's easier to talk about urination and bowels and have men suffer through it. And it's become increasingly clear that treatment regret is tightly tied to loss of sexual function, intimacy with partners, that sort of thing. Not important to all men, but the focus of this trial is going to be looking at those predominantly younger men or even older men with good sexual potency for whom they have a diagnosis of low intermediate risk prostate cancer, which needs treatment, but where we're saying, we have new technologies now. Can we try to attack the sexual function angle? The key differences now as to what we're trying to do to reduce sexual function in this trial are going to be surrounding the use of MRI, basically an imaging modality that visualizes the prostate in an exquisite manner, and as I mentioned before, can pick up clinically significant prostate cancer through multiparametric contrast-weighted diffusion sequences, things you might hear about, and try to ask, if we know where the dominant disease is, if it's lateralized in the prostate, can we take the radiation stereotactic approaches, which limit dose to surrounding structures in a much more careful and precise way than we could do with 44 treatments across 8 weeks, use the rectal spacer, which pushes the rectum out of the way, so we no longer are only focused on sparing the rectum, and ask, can we now start sparing the vessels and nerves immediately adjacent to the prostate, similar to how the surgeons do it, and perhaps improve sexual potency after radiation treatment than without sparing those vessels and nerves. We like the idea because radiation and surgery are generally similar in sexual potency declines, but overall, in average hands, there's actually a slightly better outcome rate of sexual potency, at least in the first couple of years of radiation. It's debatable, but most people accept that to be somewhat true, and that yes, the surgeons have shown that if you do nerve sparing, you improve their sparing rates of sexual function. So we combine the best of both the worlds, stereotactic radiation, the ease of that, and then the nerve sparing of surgery, and try to get better outcomes. So it's really a collaborative effort with the urologic colleagues. No one's trying to say anyone's better than anyone else. We developed the spacer gel program with the urologists, and we're trying to spare the nerves and vessels. But we don't know if by sparing these vessels and nerves from dose we'll actually achieve that outcome. We could be wrong about the anatomy. We could be wrong about our setups. There's always risk in these questions, and this institution, very well known now through your trials, only assesses these questions in a controlled, randomized manner by taking a scientific look. And so we're doing a randomized trial, in which one arm, we will not know who these patients are, gets the sparing approach I described, versus the other arm gets a standard radiation approach, which is our top flight treatment anyhow right now, with decent potency rates compared to other modalities, and see if we can't reduce the sexual dysfunction rates by at least half.
Wow, that's a large goal.
Yes, and we'll see. But you got to take trials in a controlled manner. It's a multi-institution effort across the country. We're not the only ones doing it. And so we believe this to be the right time to do it. This is based on a lot of work that's come for the last 10 years from other institutions we're working with. And so I think we're very proud here to be working with the makers of the spacer gel and institutions that ask this question.
Amazing. Well, we have about 5 minutes left, so now's a great time to get those last minute questions in. So we're going to wrap up and let our physicians go back to clinic. Dr. Hannan, looked like you wanted to add something.
Nothing particular.
Okay, well then in that case, we just talked about the Poten-C clinical trial. There's another clinical trial underway, high-risk prostate cancer. How is that trial? What is involved in that?
So on the other side of the low intermediate risk patients, where the focus is on preserving, reducing side effects, in the high risk spectrum of prostate cancer, there the focus is intensifying treatment to make the treatment more effective, because the control rates are so much lower and the outcome is relatively much poor. So that's what we are focusing that with our high-risk stereotactic radiation trial. We know from a lot of conventional radiation data that if we keep increasing the dose of radiation, you actually get better control rates. But with stereotactic radiation, we are taking that to another level, where we do a careful MRI, a sophisticated MRI, to show us the cancer lesions, and we escalate, increase the dose to a higher level, whereas the rest of the prostate seminal vesicles gets a lower dose of radiation through the stereotactic setting, and the lymph node regions all get different levels of dose, all in the same treatment, and all done within the 5 treatments. So where we saw that the 98% cure rate in the low intermediate risk patients, we think for high risk patients we can really make that much of difference, where the cure rates are down low in the 60% level. So we really think this is something that will make that impact, and this more potent radiation will increase the cure rates of the high-risk patients. This is, of course, in combination with this 2-year course of standard hormonal therapy.
Okay. All right. So we're just about out of time.
And so can I add to that just 1 second?
Absolutely.
Just, the foundation for why we're even doing this, or why we think it will work, is that we've long known that intensification of radiation does improve PSA cure rates, and indirectly there's some data showing that metastasis reduction is also seen, but with the use of brachytherapy or seed implants. So there's rationale for this, but not everyone's able to get brachytherapy. Not everyone can go through 10 weeks of treatment between the implant and the external beam treatments. So this is a very cool question on the very other side of the spectrum from what I'm talking about. For people who really need the treatments, can you make it more logistically feasible and give the intensification of radiation without putting you through the operating room procedure brachytherapy, which I like doing, but which not every patient is able to do, basically. So very cool trial.
Awesome. So final question, with respect to both of these trials, what's next on the horizon? You want to start, Dr. Hannan?
So the next in the horizon is, remember, this high-risk trial is a phase 1 trial, so we are trying to come up with what is the best dose and what is best tolerated. The next question is to really how to improve that. How to, questions like whether do we really need the 2 years of hormone therapy, which has significant side effects. Can we bring other treatments like immunotherapy in the board, where we know stereotactic radiation has immunogenic properties, and we can strategically combine that with immunotherapy to further improve the outcome for the high-risk patients. That would be what would be next for the high-risk patient population.
Gotcha. What about for the Poten-C trial?
For Poten-C, it's going to be going on for a while. This is the definitive trial we believe that will try to answer this question based on many years of work. like these phase 1 trials, which have produced this question. So we hope in about 5 short years, we'll get the definitive answer to it. In the meantime, we'll gather data in terms of patients' individual nerves and vessels. We believe in translational correlate studies during these trials. And so maybe there's individualizable ways to look at people's vessels that are most key to their sexual function. In the future, try to design maps maybe for those patients that are more actionable than just blindly picking one nerve or another to spare. A lot of it's iffy, but you got to start somewhere, and I think you're seeing 2 different ends of the spectrum of how these studies are, or what populations people are looking at.
Absolutely. Well, I want to thank both of you for your time, Dr. Hannan and Dr. Desai. It's been great. Thank you for sharing all this information.
It's a pleasure to be here.
Absolutely. So to our viewers, just know that this will be available here on our Facebook page, and it'll also be available on our YouTube channel later this afternoon. So if you have additional questions, please post them there. But in the meantime, I want to thank you for tuning in today. Have a great afternoon.